Welcome to Spine Academy. In this video, we're going to discuss the anterior cervical exposure corridor and some of the indications for surgery from an anterior approach. This is an excerpt from a broader course in which we discuss on a high level the many different types of cervical spine surgery. If you're interested in seeing the full video, we've left a link in the description. There are many different surgeries that we do from an anterior approach, but let's talk about the exposure and the approach generically. If you look at the spine from the side, you can kind of see here with the skull in place that here's the spine. This person has a fair amount of pathology at these levels with some instability and even some kyphosis. But you can see kind of with the frame around it that the front part of the spine represents everything from here, and that is what we consider anterior approaches, approaches from the front of the neck, which would be kind of here on me. Approaches from the back are approaches from the back of the neck, obviously. Now, if you were to take a slice of the neck like this, it would look a little bit like this. So here you could see the spine itself, you could see the spinal cord and some of the nerves on either side, and you see the structures that it sits within. So here you can see some of the muscular stuff in the back, but we're going to talk first about the anterior approach. So the anterior to the spine, or in front of the spine, which is this direction here, you can see that there are some important structures. There's the esophagus, the trachea, which kind of mediates swallowing. The esophagus carries food from your mouth down to your stomach, and of course your trachea helps with both breathing and also with phonation, which is like voice and so forth. Those structures sit immediately in front of the spine. Now, you do have some big blood vessels that are off on the side here. When we refer to anterior approaches, we're talking about approaches that come from here. So let's talk about what structures you can see well with that. Here you can kind of see if you came in from the front, and not through these structures, but from the front, you would have access to these structures. You'd have access to the disc, to the front of the spine with the nerve on one side, the nerve on the other, so you can access both sides. And you could also see the spinal cord here. You can access structures that are in front of the spinal cord. So the anterior approach is an approach from the front of the neck that allows you to target or address pathology that is in front or anterior to the spinal cord and the spinal nerves. That is generally what an anterior approach is. Now, obviously, we don't go through those structures, so the way that this is done is that we generally make an incision. I mostly make incisions that are horizontal. They go in a skin crease of the neck. And then you can dissect some very superficial structures, and there's a very natural plane that gets you to the front of the spine. So again, you can access the disc, the spinal cord, the nerves, you can access structures in the front, but you go between some structures and you move the esophagus and the trachea and stuff to one side. I generally make a left-sided incision, so this should be on the left, and these structures would be pushed off to the right. And even if it looks quite extreme here, you're only really pushing it about 1 centimeter to the side. You're kind of creating a boundary here, or a fence to protect some of these structures. You really don't have to move them a whole lot. And that is the exposure that we use to get to the front of the spine, regardless of the specific surgical technique that we're doing. So now, if you imagine looking at, again, the pathology, we don't go through this, but it allows us to address pathology here. So typical indications for which we do anterior approaches are when people have pathology in the front of the spine. So if you look at a sagittal slice, here you can see a very simple situation where somebody has a disc herniation between C5 and C6. This is causing some pressure on the spinal cord. If you were to take a slice of it like this, you might see a picture that looks like this. And here you can see this disc herniation pushing on the spinal cord and pushing on the spinal nerve on one side. This is a situation where somebody has a disc herniation and has pressure on the spinal cord and pressure on the spinal nerve. And that is a very common situation which we would address from the front. Now, because we're going in from the front, the pathology doesn't always have to be way off on one side. It can even be right in front of the spinal cord. And when you're coming in from the front, you can access this directly, because again, we're coming right down the center. This is easy to remove. You can also have pathology at a few levels. It doesn't have to be at one level. And so if you look at a slightly different sagittal slice, here you can see this person has pathology at 3 different levels. The pathology is mostly in front of the spinal cord. So it kind of makes sense to address this from the front if permissible. It's all pressing on the spinal cord, and you can access multiple levels. Most of the time when I'm doing anterior approaches, it's really ideal for 1 or 2 levels, sometimes 3 levels. I'd say the lion's share of when I do it is for 1 or 2 levels, but 3 is certainly permissible. And you can do more than that, although I think that's a little bit more uncommon. You can see when you go in from the front, you cannot access pathology that is behind the spinal cord, right? If you come in from here, you can't go through the spinal cord to get to that. And similarly, when you come in from the back, you can't get pathology at the disc level from the back. So understanding where the pathology is, and we use MRI and CAT scan and x-rays to do that, helps a lot with trying to pick the right trajectory. Now, there are other things besides disc herniations where an anterior approach can be super valuable. Here's an example of somebody who has some disc degeneration. Here you can see there's like very little disc left between C5 and 6 and between 6 and 7. So this is the C5-6 disc. It's got a lot of degenerative disc disease, a lot of disc height loss. You can see that that's true at C6-7 as well. A lot of times when people have pathology like this, they have a lot of bone spurs, and if you took an axial slice here, you might see something that looks like this, where you have all these bone spurs kind of helping compress the nerve here. You can see there's some bone spurs in the back as well. And this is an important illustration because if you picked an approach from the front, you could get the pathology from the front. Maybe there's a herniation on the other side or something. You could remove the bone spurs here. You can remove the pathology that is in front of or anterior to the nerve and the spinal cord. You cannot get to the pathology that is behind it. So in a situation like this, you would very readily, I think, be able to address part of it and free up the nerve enough to create enough room. And that would be sufficient from a foraminal decompression perspective. The other thing you can do when you go in from the front, and we'll see this more when we talk about specific procedures, is when you go in and remove this disc, you can distract it, you can jack it open, you can kind of increase the height of it and put a spacer in there to kind of occupy that space. And in doing so, you can restore height and you can restore alignment. So a situation like this is ideally addressed from the front if you're trying to help correct alignment. So in summary, anterior cervical approaches are approaches from the front of the neck. They can address pathology that is in front of the spinal cord and the spinal nerves. It's ideal really for 1 to 3 levels, although more can be done. I would say the lion's share of surgeons and the lion's share of anterior approaches are ideal for 1 to 3 levels. Usually the levels in question are between C3 and C7 because it's very hard to get very high and very hard to get low. It can address pathology on one or both sides. So it can address bilateral pathology because it's a midline procedure. Even if the incision's off to one side, you get right to the middle and expose the full width of the spinal canal, and that allows you to decompress right, left, or both. It's great for alignment and disc height restoration because, as I showed in that one illustration, you can take out whatever disc is there and distract that space open and restore height to that level, which is great for disc height restoration. It's great to restore volume of the foramen that the nerve is coming out of, and it's great to restore alignment. When you go in from the front, because you're moving some of those structures to the side, even if it's only moving it 1 centimeter to the side, because you're moving it to the side, often people will have some degree of swallowing and hoarseness issues. And I tell people more or less to expect it for a couple of days after surgery, but sometimes people can have permanent disruption of their swallowing function and their voice. Generally, surgeries from the front are a little bit better tolerated in younger patients because they often don't have a lot of pre-existing voice problems and swallowing trouble, and their tissues tend to be a little bit healthier and their esophagus tends to tolerate that a little bit better. Surgeries from the front have a very low rate of infection, and it has to do with the way your body is made. There's not a lot of dead space. When we do these surgeries, we're usually dissecting between structures, and you can very freely kind of mobilize those structures, almost like you're looking in a window, creating a little space, doing your surgery, and then on the way out, everything kind of closes up to kind of close that space back down again. So for a variety of reasons, infections from the front are incredibly uncommon. For all of these reasons, surgeries from the front are a real workhorse procedure and a really valuable approach to the cervical spine that your surgeon may find relevant for you. Having said that, there are different types of surgeries, and we're going to talk about them specifically next. Thank you for watching this video. I hope you found it informative. If you've enjoyed it, please like and subscribe. If you have any questions, comments, or ideas for future content, we'd welcome them in the comment section below.